Today we are going to see an interesting case report. How does a fat changes the fate of multiple gingival recession? I'm Dr. Mohanapriya Michael, voice behind dental shots. Let's move to the case report now. As we all know, the gingival recession has a multifactorial etiology. So it may be due to anatomic factors or due to aging or due to pathological factors like smoking. So the gingival recession leads to sensitivity, pain, caries, plaque retention, poor aesthetics, and ultimately tooth loss. The extent of gingival recession increases with age. If they are a smoker, it increases, especially in the buccal sides rather than the lingual sides, it will increase, and the subgingival and supragingival calculus areas, the gingival recession's extent may increase. And also the most commonly affecting the buccal surface due to rigorous toothbrushing and poor oral hygiene. So each and every surgical procedures has a varied clinical outcome, starting from the free soft tissue graft to pedicle soft tissue graft or a GTR technique or bilaminar technique. So the ultimate aim of doing a root coverage procedure is to restore the gingival margin to the cemento-enamel junction. So the predictability or the success rate all depends upon which Miller's class 1, class 2 has a good prognosis after the surgical procedure. A moderate one would be class 3 and a poor prognosis would be class 4. Here is a patient case report where a 38-year-old healthy male reported with a sensitivity in the upper right back tooth region for the past 6 months. On clinical examination, we found that there is a Miller's class 1 gingival recession in 13, 14, 15 and 16, and there is an adequate keratinized gingiva with attachment loss of 2 to 3 mm. There is no pocket, no furcation involvement, and the tooth are vital, non-mobile, and acceptable amount of bony support is evident. So we provisionally diagnosed this case to be a chronic localized periodontitis in relation to 13, 14, 15 and 16. So the treatment plan was to do a phase 1 therapy followed by oral hygiene instructions and root coverage procedure, which is a periodontal plastic surgery with the help of fat. We did an investigation starting from the common blood investigation, radiography. Before proceeding with the surgical procedures, what we did, we will just have a review of literature starting from the anatomical structure of the buccal pad of fat and its clinical adaptation. As we all know, it has 3 lobes, anterior, intermediate and posterior lobe of buccal pad of fat. The posterior lobe has 4 extensions. The buccal, pterygoid, pterygopalatine and temporal extensions are present in the buccal pad of fat. Scientific evidence says that the volume of the buccal pad of fat is 10 cubic centimeter, length is 60 millimeter, width is 50 millimeter, thickness is 6 millimeter. Coming to the vascular supply of the fat, buccal pad of fat, it is superficial temporal artery, infraorbital artery, transverse facial artery with the internal maxillary artery. Several nutritional vessels exist in this lobe and together form a subcapsular plexus. So our case report, which we are going to discuss, will use a pedicle buccal fat pad as a subepithelial graft for the root coverage of multiple gingival recession defect. Let's now see how did we proceeded with the surgical procedure. The recipient side, we gave an LA and followed by the sulcular incision was made anteriorly up to canine region. After the sulcular incision, we elevated the full thickness envelope flap. There is no vertical incision made, only envelope flap is, and the recipient side is debrided well. Root biomodification is done. Let's now see how did we harvested the pedicle buccal fat pad from the donor site. According to the scientific literature in the open access atlas of otolaryngology, head and neck operative surgery, there are totally 3 approaches to get the buccal pad of flap as a flap. So we have to incise the buccal mucosal membrane 1 centimeter below the opening of the parotid duct, which is called Matarazzo method, or we have to incise behind the opening of the parotid duct, we call it as Tuzin method, or we have to incise the superior buccogingival sulcus. So these are the 3 approaches. We selected the last approach. As we selected earlier, we proceeded with a 2 centimeter horizontal incision in the highest point of the vestibule, extending backwards above upper right center, second molar region. After the incision we made a blunt dissection through the buccinator muscle and fascia with the artery forceps. And then we gently mobilize the body of the pedicle buccal fat pad, and the buccal extension are gently mobilized, and we should not disrupt the capsule and vascular plexus, and also we preserve the base as wide as possible, and we spread over the buccal pad of fat all over the roots of the right maxillary posterior teeth where the defect are seen. Then the pedicle buccal fat pad is adapted and secured tightly against the maxillary root with an independent sling suture with 5-0 vicryl, and also the vascularized flap was advanced and secured and immobilized to an adapted pedicle buccal fat with the help of vertical mattress sutures, ensuring the flap should be free of tension. This is the immediate post-operative view. And then the non-eugenol periodontal plaque is placed and the oral hygiene instructions were given, and the review call has been made with a follow-up medication, post-op medication we have given. This is the 8th post-operative view. The post-operative healing is uneventful. This is the 2nd week post-operative view. This is the 3rd week post-operative view. This is the 2nd month post-operative view. At the end of 2nd month, we found that the attachment gain is 3 mm. So when you compare all the methods, the subepithelial connective tissue graft and the free gingival graft has a little disadvantage because it needs a secondary donor site, and also the survival rate is compromised it all depends upon the circulation of the recipient site, not the donor site. As the demand of aesthetics and functional treatment are increasing, the complete root coverage procedures are famous now. And hence the pedicle graft has a predictable clinical outcome because it has a high vascularity which determines the high survival. The pedicle buccal pad of fat is not subjected to lipolysis, so the advantage is that the proximity of the donor site to the recipient bed, it is easily accessible with minimal morbidity, and the rich plexus of blood ensures the survival of the flap, and axial graft pattern has the vitality and resistance to infection. Interestingly, the stem cells are present in the pedicle buccal fat of pad, which has a role in periodontal regeneration. I hope this video would have been a great inspiration, using a fat to change the fate of multiple gingival recession. If you have not subscribed to our channel, kindly subscribe to Dental Shots, and if you like it, like, comment below and share with your colleagues. Have a great day. God bless you all.